2021, and we're gonna see today SEVA VentRounds. We have 4 waveforms that are fresh out of the oven. As you know, our COVID burden has increased, and that gives us more interactions to read from, unfortunately. But let's learn together. So the particulars for today is our disclosures is we will discuss ventilator modes, no endorsement of any particular mode, manufacturer or company. We love all. We're good with it, everybody. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And today it's going to be me. Rob will not be with us today. So I do receive fees and royalties from books, chapters, and some lectures. And I'm a co-owner of a patent, which has nothing to do with what we're discussing today. Well, it has something to do, but I will not discuss that at all. These are recorded sessions. As you know, they become available in YouTube in the next 24, 48 hours. So please keep your microphone muted. The moderator may call upon members of the audience to comment, and feel free to do so. If you have something that you want to comment to us, either put it on the chat and I'll call upon you. I have 2 screens so I can see both at the same time. The next thing is we do have the WebEx poll, but we're not going to activate it today because there's a fair amount of instruction to do or to learn about these curves on their own. And there's a QR code at the end of the session, and that's for all the Cleveland Clinic employees. They can get CME. Right. So this is the first waveform. I'm going to put it there for a second for you to digest it. And then I will ask any of our team members, our fellow members, if anybody's interested in reading it. Again, I will point this out. This is a safe space. I will tell you, I learned from each one of these curves. We all get to learn. So I know that it may be daunting to do it in front of everybody, but such is life. I mean, we're here to help you through it. So if anybody wants to read it from the fellows, please go ahead and either unmute yourself and tell me, Eduardo, I'm in, or send me a text or a chat. Any of our fellows?
I can go.
All right, who's this? Udi?
Uni.
Udi, all righty. So what's the tag, Udi?
So I'm cheating here. So I'm gonna say PCCMVA because it's PRVC. But if I go about it systematically, the volume, the flow waveform does not look the usual kind of machine controlled flow. So therefore, I think it should be pressure controlled. There's a lot of PMUS in the pressure control. So yeah, I mean that's where sort of my analysis of the tag stops. But yeah, I mean it doesn't go. And CMV, why is it CMV? Because because it seems that every breath is initiated by the patient, but I can see by the color change. Cycling wise, I would say that the patient, I don't see any flat lines of zero flow, which would mean it's machine cycled. But yeah, I think CMV. Why is it A? It could be, I mean, we can think of it set point. All the breaths seem to be the same. It's certainly not dual, but I think I'm just going back by the PRVC tag. Load, like I said, in inspiration, and to see the load, you really want to see both the waveform pressure and flow. There's a lot of PMUS in the load. In expiration, I think there's expiratory work also. So I would say also there is PMUS there. Looking at the time constant, I mean, it's very difficult to see the time constant. I would just say it's PMUS. Going to the PV discordance trigger. I think the patient, if you can see the pressure waveform, there is a tremendous amount of negative pressure when the patient is taking a breath. So I would say the patient is doing a lot of work, but is that I mean, in terms of timing or phase shifting, I would say it's still normal. I don't see a lot of phase difference. It's a pretty fast rate. Um, Inspiration, of course, there's tremendous work shifting. You can see in the pressure limb how it is deflected so much to the baseline, where it's supposed to be flat. It's in fact, I mean, when yeah, I mean this is impressive. Um, and then as the patient kind of, I think the PMAS is probably extending until the peak. Uh, and then it's showing a sharp peak. So I think it's a severe work shifting. Cycle, yeah. Um, in terms of cycle, I think again it's seems normal cycle. Uh, could it be because I'm seeing a lot of work shifting? Could it? I'm just wondering whether it could be late. No, I think I'm going to stick with normal. I mean, let me think this through. I'm trying to see if there's any phase shift difference between PMAS and PVent. So, uh, is there there is a negative deflection after the in the pressure waveform after the pressure goes down, but I think that's just the expiratory valve or normalization. So I don't think that's necessarily a matter of cycling. So I would say, yeah, this is normal. Expiration, you can see how the patients, how the negative flow is going away from the baseline. So I think that's expiratory work. Yeah, sorry it took time for me to work it through.
No, Woody, well, good job. So let's go through your read as you did. So I did include the PRVC here because I thought that if I showed you this waveform on its own, it would be really hard for you to know what the algorithm is. But you recognized that this is pressure control, and so you just for all of those that are doing this for the first time, it's we know it's pressure control because the flow is not controlled, and you can see that the flow, even though it's pretty regular and nicely, but it doesn't have a geometric shape, and usually it's either a square or a triangle. Some ventilators can do sinusoidal, not this one. This is a servo U. It's CMB, and you recognize that. I mean, it's patient trigger. Very good job there, Udi. And we know it's CMB because you can see here it's PRBC, and if it's PRBC, that means that all the breaths are mandatory. That's how it should be. You set an I time for this. There's a hint that this is mandatory, and it's this little step that you see over here. The patient was exhaling actively. I mean, he's going from inspiration to expiration. And as he's going down, there's this little, the valve suddenly, the I time finishes, and you get that little. But whoever was the respiratory therapist that was taking care of the patient, this patient is breathing with a lot of effort, really actively in and out, was able to adjust the I time to achieve that I time that the patient needed. Which is a labor of love, being at the bedside, moving that time. And you could ask why would we be even on this mode under these circumstances, but we'll talk about that in a second. The second item, and so then finally there's the adaptive part, Udi, that you read, and if you remember the adaptation, what happens with adaptive is you set a target tidal volume, and the machine will adjust the inspiratory pressure up and down to achieve the tidal volume that you want. And so if the patient is doing effort and he's getting more than you set, let's say that what you set was 400 cc tidal volume, so I'll put this line to denote those 400 mLs. The ventilator is going to drop the pressure as much as possible, which in this case is the baseline PEEP. And so this patient essentially is breathing unassisted in terms of the inspiratory effort. They're not getting any any support through that. And so that's the adaptive targeting. So you can see right now a patient that is essentially breathing on his own with a mode that it's CMB, that it's not providing much support because of the way that it's set. So that's one of the challenges of PRBC. It doesn't mean that it's a bad mode, but in patients that have very high respiratory drive, the support is going to go down. Questions there? Yes, thank you very much, Ahmed. So Ahmed is pointing out that the tidal volume is changing from breath to breath. And so because it's pressure control, it will depend on the PMOS from this patient. So very, very good. The PMOS is the only load that you can see here. Essentially, the PMOS is doing all the work of this patient. Whenever there's PMOS, you cannot see the time constant. And if you cannot see the time constant in pressure control, then you cannot say if it's elastic or resistive. So in this patient, I'm blind right now. I know that he's doing a lot of effort. I don't know why he's doing, if this is elastic or resistive. I cannot tell from the waveform right now. In terms of PV discordance, this is a good one, Udi. In terms of triggering, there's a lot of trigger work. There's no doubt about it. I mean, if you consider, I don't know where the peak was set, but all of this area, if we consider this the baseline, all of this area that I'm shading is work that this individual is doing, and it's going below the baseline. And then the ventilator triggers, boom. And you can see actually how it crosses there's no delay on crossing actually it's triggering even before. You can see the changing color before it reaches the changing flow. It's just the peaking flow. So the patient is triggering and the machine is actually pressurizing relatively fast. It doesn't seem to, when it's pressurizing slowly, you expect something to look a little bit more like that, or I mean, I'm probably exaggerating, but something like that. So it's pressurizing rapidly, pressurizes all the way to the top, and then because it's in adaptive, it's just giving very little support. And actually, if you imagine that it pressurized, it overshoots, and then probably this is the baseline. So all of this area over here is the patient working on its own. It's all effort in. The patient is inhaling actively. So I think the trigger, by all, you just cannot do it better, is normal. The patient, there's just a lot of trigger work. The machine is triggering as fast as it can, but this patient is doing all the effort in the universe. So I will agree with you on that one. It's not pretty, but I don't think it's an issue with the ventilator doing it. It looks that if it was acting late, you would expect, if life was fair. So we can argue here. I know the lip is gonna throw me a rock, but if life was fair, you would want it to start actually right here, right? You would want the ventilator to trigger all the way over here when the pressure starts dropping. But it doesn't, which is pretty interesting. Thank you, Dilip. You see that. So technically, this would be a late trigger because we have evidence of that, but the machine is doing as much as it can right now. But yeah, so late probably makes much more sense under these circumstances. Inspiration, I do agree with you. There's severe work shifting. This patient is breathing at the baseline. And actually, the only time that the pressure goes above is when the patient is exhaling. And so the muscle starts relaxing. And you can see how the pressure goes up, but it's supporting the period of time that the patient is doing nothing. So I think that this is, you're absolutely right. This is work shifting, which in my eyes is severe. And the cycle under these circumstances, it would be, this one probably is late, as you were pointing out, because there's this little interruption, but whoever set it up, it was very nice. And these peaks are related to the very fast relaxation of the expiratory muscles, and the ventilator cannot control it. And then there's definitely expiratory work, and we know that because it doesn't decay exponentially, and all of this is all of this area that I'm shading is work by the patient. So you can see work here and work here. So this patient is essentially breathing a lot in and a lot out. I'm looking to the comments. It says, would a pressure trigger improve sensitivity in this case, given that the patient sucks so much pressure during trigger? That's a great question. I think that this is not an issue with the flow trigger. It's just that the patient is doing so much effort that the ventilator cannot keep up. And it's pressurizing the system, but there's a delay and the patient is just going faster than the ventilator can achieve it. And so I agree with Ahmed that flow trigger is usually more sensitive than pressure triggering, just because of the nature that it just needs the flow to cross over. So that's what I would read now. I want to ask I want to stop there, and then I'm going to ask a couple of questions about what to do then. What is the best alternative for these patients? So, is there any comments from the audience that want to do it? So yeah, Dilip states these triggers need to be more intelligent, and the question is, I presume algorithms could detect this type of pattern to detect that the ventilator is triggering too late, and then automatically accelerate the triggering, or how do you would say it, be preemptive and just shift the triggering ahead so that it could avoid that. So without a doubt, there's IntelliSync. There's some ventilators that have now some automatic features to achieve improved synchrony in terms of triggering and cycling. So that exists and it's coming out. Oh, okay. So we're starting to get some other comments. So alrighty. So let me the question is what to do for these patients. So I have a couple of comments. There's one from a man thing who tells us that he would like to do a reasonable amount of pressure support. On the other side, we have Hara telling us, well, I would do pressure support or paralyzing. It all depends. Then Mohammed tells us, I think we should change the bend mode, as the PRBC will give less as the patient does more PMOS. And then Udi says, yeah, you're right. Acidosis, anxiety, then if all corrected, then sedate. But it all depends. So let's introduce here a concept, which is understanding when I think about how to approach, or we think how to approach mechanical ventilation, it's always useful to see the patient and think of them under the three goals of mechanical ventilation, which would be safety, comfort, or liberation. And the reason why I like to do that is because I choose the one that it's the primary. It doesn't mean that I abandon safety or liberation, but it helps me understand how I'm going to act on it. So I presume that a man chose pressure support thinking about comfort, and I would ask a man to talk a little bit why he chose that. Man, can you speak? Yeah, go ahead.
Awesome. Yeah. So again, if the goal is, again, depends on the goal. I mean, if you're okay with the tidal volume and we are moving towards comfort, then that's one option, is to do pressure support if you don't have a servo targeting mode, for example, in servo eyes. So what I would, like, we discussed, essentially right now the patient getting no support, maybe even negative support in this mode. So with the pressure support, it will at least guarantee some support from the ventilator based on the degree of pressure support that you set. And since the patient's so active, then also you would probably have better flow synchrony with pressure support versus CMBS or pressure control. So better synchrony, more support, and then we can just all titrate the degree of pressure support up as needed based on patient comfort, and take it from there.
Excellent. So really good. I like to think about this when I'm thinking about allowing synchrony. Great job, Aman. Really good. Is if you think about synchrony, the less things you control on the ventilator, the less issues you're going to have with the patient. So if I'm controlling the trigger and saying when the rate is going to go in, or I'm controlling the cycle, so the I time, there's more chances, or I'm controlling the flow, there's going to be more chances of discordance. The less you control, the better the concordance there's going to be. So this late cycle that is over here would disappear in a sense if you had him on pressure support, as you're mentioning. And the second one is this work of breathing relationship that you're bringing up. And right now, this is P vent. So the pressure delivered by the ventilator and the pressure from the patient. And if you're talking about the pressure right now with PRVC, the pressure goes down, and actually this patient is crossing down here. It's almost not getting anything. So this is the PCCMBA. What you're proposing is to actually set constant pressure from the ventilator, which would be PCCSBS. And what you would do is that you would move up and down the amount of pressure support from the ventilator to achieve or offload the pressure from the patient, or maintain a work of breathing from some constant support from the ventilator in relation to the patient, to support him if that is inappropriate for them, so that they don't use more of their cardiac output going to the respiratory muscles if they're acidotic, or if they're anxious and they're that they have more support on what they're getting. That's really good job, Emma. Now I see here. Absolutely, Mohammed. So why the patient is intubated? So that would be, if your goal is liberation, immediately you start to say, this patient is breathing on his own. Do we need that tube into this human being? I mean, should we remove it and let him be? But I agree with you. You first have to check if there's acidosis, anxiety, pain, a very high BQ mismatch. Sometimes we see these patients breathing really fast, and the minute ventilation is, 20, 15 liters per minute. And yeah, they're doing all the work of breathing, but their gas exchange, with that, they have a CO2 that is normal or elevated. And you know that when you take them out of support, they're going to be on their own. And then they're going to be in trouble again. So you have to factor that in, definitely. There is a comment from Juan Martin. First, we should evaluate the patient, yes, and why he has such a high demand for flow and high PMOS. Absolutely. Juan Martin, this is somebody at the bedside. This is one of those waveforms that when you're walking by, you cannot let go. You have to grab the RT and bring him to the bed, and with the RT try to solve this puzzle, because otherwise this is a patient that it's working really hard. And if your goal was safety, I think that which is gas exchange and prevention of ventilator-induced lung injury, this patient is not achieving your goal on prevention of ventilator-induced lung injury. If we can argue about PCILI and if he's getting self-induced lung injury, I mean, all of these items come to terms. But that's why coming in order and saying, well, if my goal is safety, prevention, gas exchange, and prevention of lung injury, then this patient needs to be sedated, figure out what's going on, fix what is going on, and then let him come back to earth. Because there's no mode that will keep this patient within tidal volume with this amount of PMOS. You can put him on volume control, but he will remember you and all your family for the years to come. All righty. Any other comments? Yeah, so the lipus is actually asking for servo on this patient, in which the patient, if we put a servo, the relationship would be this one, right? So the more effort from the patient, the more support from the ventilator, and that would be PCCSBR. What I would say about that is, every time, if a patient has this level of work of breathing, this would be great, but usually they will still be doing all of that unless you solve the underlying cause. The mode will not take it out. All righty. Udi, great job. very nice comments from the audience. I think that we learned a lot. Just this waveform is a stop and take care of me waveform. Any other comments? Yeah, absolutely, Moha. This is one of the disadvantages of PRVC. People, so if you come and see this patient, you will probably see a compliance of around 150 to 200 because the patient is doing very large tidal volume with very little support from the ventilator, and the ventilator screen over here is going to have the dynamic compliance, and it's going to give you a very high number, and you would be, oh, he's improving, and this patient is just doing all his effort on his own. Great comment.
Dr. Mireles, one question.
Yeah, go ahead.
It's probably an oversimplification, but thinking of the diagram of the work of breathing, P-vent and PMAS, in simple terms, is it okay to think of PRVC as sort of a weaning mode? The vent backs off as the patient takes over, whereas where if you want to support and increase the vent support as the patient's work of breathing going up, it's exactly an inverse relationship. So it's almost like you almost want to get to that start PRVC when you're going in comfort or going into comfort rather than when the patient's in the safety aim range.
Yeah, thank you, Udi. So when we did this, when we classified the modes according to their advantages, we did put some points on PRVC for weaning, because you could use it as a weaning mode. It all depends on your protocol. So you can imagine, and there's been literature on this, in which patients that are coming out of the OR, that are coming out of paralysis and sedation and whatnot, as they start getting stronger, they start breathing on their own, and so the pressure delivered by the ventilator goes down, right? And under those circumstances, a protocol, if you protocolize this within your environment so that the team knows, okay, he's going to be on this, when the pressure starts dropping from where he was, that means that he's generating more support, and at that time you're going to change him to X, Y, or Z, or you're going to do these interventions. And so under those terms, you can consider it. It also has so it all depends where you want to put it. It does meet some of the goals of liberation. It does meet some of the goals of comfort, and it does meet some of the goals of safety. Oh, yeah. So Jorge Vargas asked, so in a patient with septic shock on high dose pressures, is PRVC one of the worst of modalities, given that the cardiac output will increase in this modality due to the high PMAS? Well, that will happen with any mode of mechanical ventilation. The challenge is that with PRVC, you will have less support. The same with volume control, Jorge. So, but you're thinking on the right lines. Is it for this patient, how much work of breathing? So if I have a patient with high work of breathing, for whatever cause you want, I don't think about a PCCMBA or volume control CMBS mode, volume control or PRVC. I don't think on those modes, because I know that the ventilator is going to drop the support, and then I'm not giving him support when he needs it. So I think more on those patients, as a man thought about pressure control, pressure support, or a servo mode. So I would not say it's the worst of the modalities. I would say it's within those modalities that I would not use. Great question, Jorge. All right. So here comes another one. I'm gonna let their sit there for a couple of seconds for you to digest. Anybody wants to read this from our fellows? Have no fear. You guys can do it. Anybody?
I guess I can try, Dr. Mireles.
Who's this?
Michael.
Hey, Michael. All righty. Hit me.
Okay, so I guess start with what is a tag. Based off of this, I think it's probably PCCMVS. And that's just on the basis of looking at the waveforms. The flow waveform has its own shape, and there seems to be the pressure seems to remain constant. And yeah, that's just based off of what I think there. The load, inspiratory load, I think is elastic. Oh, actually, no, I changed my mind. Resistive. And the expiratory load, I think is largely PMOS. And then for the discordance for the trigger, looks like it's a pressure trigger. And based on the first ones I see, it seems like it's probably late. The inspiration to me seems pretty normal. And then the cycle I think is early. And then I'm not sure, but I think the expiration cycle is also normal.
Thank you, Michael. You see, great job. Thank you for jumping on. So let's
No problem.
go in order from this. So the first thing that you recognize is the tag. So it's pressure control, absolutely. The pressure is controlled through the breath. The flow and the volume are resultants of the pressure and the applied to the respiratory, the resistance and the elastance. So that's what you're controlling. This is certainly CMB. The reason why, although every breath is triggered by the patient, you can certainly see that the ventilator is being cycled by time. And there's some hints there. One of them, you caught it right on, is that there is an early cycle. So that means that the ventilator is cycling earlier. All the items seem to be the same amount. And then you have obviously the pressure control tag over here that helps you identify for this ventilator what we're dealing with. And finally, this is set point because it's a constant, the pressure remains constant throughout the breath. There's no other intelligence here. And we do know, and that's the benefit of having, of knowing your ventilators, is that there. So the benefit of knowing your ventilator and learning the tags is that then you know exactly what tag your ventilator is. So I suggest that you grab one of our Rosetta cards, as we call them, or tag cards. Or if you have one and you need to know more about these vents, we're happy to share with you so that you know what your ventilator is doing. And then you just memorize them, and I mean, it comes naturally, and you will know what it's doing. In terms of what is the load, so during inspiration, imagine, Michael, right now, that this patient is taking breath, right? So I'm going to draw the PMOS for him. So he's peaceful, and I'm going to draw the PMOS in a negative way so that it looks as you're used to. So he starts his effort here, correct? So he starts doing his effort, and with that, the pressure goes down, and he continues to do effort, and you recognize that there's early cycle, which means that the patient keeps doing effort all the way, and then he relaxes, and then it comes back out. And so that the end of the breath ends up around here with his effort. Sorry for my very crooked line, but around there. And all of this is PMOS, right? All of this area, the patient is doing inspiration. And it's just a continuous effort. So instead of me being able to see my nice decay on the waveform that would tell me if it's resistive or not, I'm seeing the effect of constant pressure throughout the breath. And so if there was no PMOS, I would agree with you that this looks like resistive because it's not reaching zero by the end of the breath, but because there's early cycle, this makes me think that this is just PMOS and it's hiding whatever is happening there. Does that make sense, Mike?
Yes, yes, it does.
And then the patient does this effort, so there's PMOS there that he's trying to inhale, and then he relaxes. And this looks to fall in a nice, actually you can see it here a little bit better, an exponential decay. And so normally this should have looked something like that. Should have looked something like that. And then he decays nicely down. And that would tell you exactly where or what type of where he's at. It doesn't look to be particularly long. It reach 0 before he triggers the next one. So I would say this is probably elastic, if anything, with a little bit of PMOS at the beginning, but he's not actively exhaling. You see the exponential decay nicely on both of them, or trying to do that. In terms of trigger, and well, we'll talk about the other clue in a second. In terms of trigger, I agree with you. You caught this very nicely. This is a pressure trigger. And the reason why this patient is a pressure trigger, I cannot tell you. I just took the picture. But without a doubt, the patient now has to do an amount of effort. And I'm going to amplify this so that you can see this a little bit better. So you can see how the patient has to drop the pressure all the way over here so that it can trigger the breath up. And that correlates down here. If this patient had been an UDI, you asked that, or somebody asked about switching him to flow, you can see that the patient already crossed the 0 baseline here, and it had to go all the way up here to actually start the breath. So if this patient had been on a flow trigger, perhaps the trigger time would be smaller, if that makes sense. So I do think that there's some degree of lateness. It's not terrible. I mean, it pressurizes afterwards, but I think that this is a ventilator setting issue that we did ourselves as we were setting this ventilator on. The next item that I would point out. So you said inspiration is normal. It does look normal. I mean, there's a little bit of work shifting, but that is totally normal. I would not change anything. The cycle is early, and we talked about a fair amount already, but each one of these waveforms here is a marker of an early cycle. So good determination there. And then expiration, as we discussed, seems to be normal with no PMOS. So that's how I would read it under this circumstance. So PCC MBS with the presence of PMOS during inspiration seems to be elastic load, a pressure trigger that is leading to a late trigger, and there's early cycle on this poor patient. And so the question, let me see what questions there are, and then I'll ask you again the same question that I asked to the rest, Michael, is what would you do for this patient? So what would be the cutoff time to define this as a normal versus late? And I presume trigger. Yeah, that's a great question. So in reality, the best study that I could find when we were trying to define this said that the majority of the ventilators can trigger with a delay no longer than 100 milliseconds. And that's what they have outlined. Majority of current ventilators respond within 60 milliseconds. However, you can imagine how difficult it would be at the bedside unless we had calipers, and some ventilators may have it, but not. It's hard to do so. To go to the bedside and be measuring the 100 milliseconds. So in practical terms, when you're at the bedside, the question is, can you improve this? Is there any features that the patient could have been triggered earlier? And this would be one of them, that there is a drop and the patient already crossed the 0 flow. And I would suspect this to be late from what we could do better for the patient. So it has to be, we also added in the definition that it had to be clinically significant. So anybody, including Dilipus, would say, Eduardo, I would not change anything. That's normal. and that could be okay. I mean, there's some types of discordances that we don't know if they hurt the patient or not, but they certainly add to the work that they're doing. And so I think that this could be optimized. And I see if that makes sense. All right. Any other comments from the team? All right, Michael. Yeah, shoot.
Dr.
Go ahead.
Mireles, so you don't think that there is any expiratory work that patient is not doing work and in expiration with the flow wave going away from the baseline, and because there's also a hump in the pressure wave at the same time, so I thought that there would be something.
Yeah.
And if there is any work there, then doesn't it automatically an expiratory work doesn't it automatically mean a resistive load in expiratory, because the patient's working to exhale or expire? It
Yeah.
means that there is a resistance in the system.
Well, you can have expiratory work regardless, but yes, you would be fighting against the AT tube and the whole system, but you could be working against a closed valve, and it would be not necessarily resistive, right? It would be under those circumstances you're just against a valve and there's no resistive load, it's just elastic. So we'll talk about that. I think that settles that the type of work depends on what the situation is, what you're facing as you're exhaling. But the reason why I said that is because I see the decay over here, and it looks very nicely that now. Is this the initiation of it active? I don't necessarily think so. I think this is just the ventilator trying to adjust for the patient now, relaxing the muscles and going out, and the rest of it is pretty passive.
But there's a difference in the heights of the peak at which that is occurring from the first breath compared to the second and third breath.
You mean here the peak on the pressure?
No, the peak on the expiratory flow.
Yeah.
I mean, it's splitting hairs, but there is a difference in the peak, I guess.
Yeah, which means that there's differences in the PMOS, right? So you mean in this?
Yeah.
So there's difference in the amount of PMOS that the patient was doing, and you can see a lot of PMOS, less inspiratory, less, and then more, right? Yeah. So
Okay,
that's what's causing that apparent difference. Yeah.
The difference on the height of the yeah. Thank you very much. That's a good point. All right. So Michael, what would you do for this patient if he was your patient?
I guess at the risk of sounding overly simplistic, I guess I'd probably change it to a flow trigger, and I would increase the eye time.
Okay, flow and eye time. Good. Excellent. So that actually I didn't point out this too, but you see the volume waveform, how it has this little hump because the patient is still inhaling. So that is just a concomitant that you would see if the patient is doing effort. Well, inspiratory effort. So yeah, you would do this if you want to maintain the patient on that same exact mode, right? If you were your goal was comfort or whatever you set this mode, that would be the minimum that you would do to optimize the ventilator settings on this patient so that he doesn't have what would be the side effect of early cycle? What can happen to this patient? Anybody? What's the badness of having early cycle? Breath stacking, yes. So multiple trigger, right? So actually he almost achieved it here. And one of the potentials is that why he's on pressure is that he before or she before or they before were they were double triggering the ventilator, so having multiple triggers because of this early cycle, and then they decided to change them to pressure, so to try to avoid that from happening. That could be one of them. So that without a doubt, early cycle is one of the causes of double triggering of breath stacking or multiple trigger, as you want to call it. All right, we have 15 minutes left. I'm gonna do this one just because it's very sexy. I was walking through the unit today, just la la la, and I was taking my usual pictures, and this happened. And so I would ask anybody that wants to read it to go at it, of the fellows first. Anybody wants to go at it? Any of the fellows, have no fear. Sherry is here.
I can try. I think I need more time to figure what's happening here, but I'm gonna try and do it on the fly.
Go in order. That's the beauty about this. We go in order, and you'll see. You'll get it. There is no doubt in my mind.
Alrighty. So here the tag is PC CSV S. Then there's cheating by saying it's a pressure support, but also you can see like the breaths are patient triggered. The size or the duration of the breath is variable, which tells me that he could be cycling. And you can see some indication of kind of flow cycling as well, where it happens relative to the peak flow. Now moving to the load, I'm inclined to say it's maybe PEMUS and inhalation and elastic and exhalation. I think the exhalation is quite passive and it gets to the baseline quite quick, which would suggest an elastic load. Now, in terms of discordance, so this is flow triggering. The flow looks normal. In terms of inspiration, there is some workload. Now, in the first, second, and the last breath, doesn't look like there is a lot of fork shifting. I mean, maybe minimal, if anything. I mean, the pressure is decent up there, and then it kind of comes down. If anything, there's the question of why it takes time to come back to the PEEP level. There's all this area after the flow have stopped, and it's not coming back to the PEEP right away. Maybe an inspiration, minimal work shifting to normal. But then cycle-wise, I mean, you could argue, I mean, we're setting the cycle as a percentage, but it's also a pressure support. And I don't see any evidence of continued PEMUS in the exhalatory phase. So I'm going to say the cycle is fine. Now, I'm trying to kind of decipher what's happening there in those few breaths in between. And if anything, looks like the machine triggers, it pressurizes, but then the pressure, I don't know, it doesn't pressurize actually, the pressure is staying at PEEP. And then the flow, it kind of looks like it turns into a controlled flow, which is very weird. And then it's not allowing the patient to exhale, but rather the flow stops for a second and then gets triggered again and goes up. Initially, when I saw that, I was like, is this a APRV type of thing? But that would be the pressure waveform, not the flow waveform that's looking like this. I'm at a loss. I don't know if it looks like there's a leak maybe, because like there's a continuous flow that's happening, and then the machine is supplying the flow, and that's why it's maintaining the pressure at PEEP. I'm gonna go with some form of a massive leak that's happening here as my explanation. I'd love to hear your comment.
All righty. Ahmed, this is awesome. All righty. So let's go in order of appearance. Pressure control, I agree with you. I mean, you have your cheat sheet here, but the volume is definitely, the flow is not controlled at all. So there's variation. So that has to be pressure control. As you pointed out, different I times, different sizes of tidal volume. So CSV and its set point. And this, during inspiration, I think you have the benefit of this line. I know I took this picture crooked, and I apologize about that, but you can see that there's always a little bit of phase shift between these things, but you can see how the pressure drops from what seems to be baseline here. And remember, from this is the past, all right, and here it continued, right? So here was this is what's happening right now. this is an old waveform, and right here there's a zone in which they are erasing everything. Okay, just so that you can read this better. So there's this line, and he's at baseline. You can see that it went all the way to baseline. It continues to come out, and then the patient does an effort. The pressure drops, and then finally the system pressurizes, boom, it crosses the baseline, and the patient gets a breath. And you can see that the flow was over here, and it kept going, and then the patient had to drop all the pressure, and then triggers a little bit afterwards the breath, but it takes a long time for it to get there. Then pressurizes, there's essentially no support there. He gets a little bit of support, and then he exhales. And so you pointed out very nicely this event here that we're going to talk about it. So I think that there is definitely PMOS during exhalation. I am not sure if it's only elastic. The gain is at 90. So it may be that there is a resistive load there, and I'm not seeing it. So I would say probably elastic, but there is a question in my mind because of the gain that if this is resistive, just because of how much he had to drop the PMOS to cross flow. So I don't know. Here I was a little bit in between late, and I agree with your flow and some trigger work. Minimal work shifting. The cycle seems to be so he pressurizes, so it seems to be normal. I agree with you. And then expiration, I cannot read it very well. This looks very nicely, so it doesn't. It seems to be normal, as you said. But this over here, as Aman is pointing out, whenever we see this area now in our waveforms, that makes us think about the expiratory cassette or filter, or HME being clogged, and we've had several of those that have occurred. So if I just read this one, I would say there's a high amount of work of breathing during trigger. I'm not clear why is that. Maybe he needs more support, or there's an issue with resistive load. Based on what I'm seeing here, I would change that. But then you have this thing here, and you read it very nicely. The patient trigger a breath, and then the flow just, I mean, there's essentially no pressure, and you can see down here that the patient was on PEEP of 5 with pressure support of 5, and it just continues to stay there. It doesn't even go up above that. And the flow is very high, but it's flat. When you see flat flow, it starts making you think about flow limitation. That's you're giving as much flow as you can, and it's limited by something. And then it shuts off, and again happens the exact same thing. And so the act that occurred here is that remember that there is a limitation of amount of time that a breath will go on a ventilator. And you have these also on the non-invasive machines, that you can put amount of time that they will stop pressurizing because you don't want a runaway breath or a late cycle. And then you get another breath, so it cycles off, and then the patient gets exactly the same one because there's a leak. So this is what we call a massive leak, unending flow on a patient with us. It just went the highest that it can. The patient is, you can actually see here all the volume that he got, 3,450 cc's, and then it resets, and again it goes up, and the flow is linear because there's the machine is giving as much flow as it can to pressurize the system. And so with that, you can imagine that this patient got disconnected from the ventilator as I was walking by. Sabotage, right? And so this is a classic waveform of somebody that got disconnected from the ventilator on endless flow. Alrighty, what time is it? 2:55. So with that, I'll put the CME code here. Is the CME code for the CCF caregivers. Here's the code. If there's any comments or details that you guys want to comment, the mic is open, and would enjoy answering whatever you need. Great job, Udi, Ahmed, and Michael for jumping up and speaking up. You see, but if you go systematic, you can detect every single one of these things. That's the cool part of doing it systematically. So thank you for joining us. All righty. Have a great day, and see you in 2 weeks. If you have anything to share, just send it our way, the usual way, Twitter or email. We'll read it and deal with you. Thank you. Have a great day.